Hallux valgus. To understand the mechanism of hallux valgus, we will review a brief anatomical overview. The forefoot consists of 5 rays comprised of the metatarsal bones, phalanges and the bones aligned with and proximal to the metatarsal. The hallux valgus deformity, also known as bunion, involves the first ray on the inner side of the foot. The first ray is comprised of the medial cuneiform and the first metatarsal which articulates to it, and the proximal and distal phalanges of the big toe. The first metatarsal bone meets the medial cuneiform at the tarsometatarsal joint, TMT, and meets the proximal phalanx at the metatarsophalangeal joint, MTP. And the phalanges meet each other at interphalangeal joint, IP. No muscles originate on or insert into the first metatarsal. The extensor hallucis longus inserts to the base of distal phalanx of the big toe. It aids in extension of the big toe and dorsiflexion of the ankle. The extensor hallucis brevis inserts to the dorsal aspect of the base of proximal phalanx. It aids in extension of the big toe. The flexor hallucis longus tendon, FHL, past the side of the ankle, and all the way to the plantar surface at the base of the distal phalanx. This tendon helps you flex the big toe and aids in plantar flexion at the ankle joint. Flexor hallucis brevis is composed of 2 bellies, medial and lateral belly, whose tendons attach at the proximal phalanx and responsible for flexion the big toe. At these tendons, 2 sesamoid bones develop, one on each side. These sesamoid bones are located under the metatarsal head and numerous important muscles, ligaments and tendons are connected to them. They, although small and seemingly insignificant, play an important role in the function of the great toe by absorbing weight-bearing pressure, reducing friction, and protecting tendons. The adductor hallucis muscle arises by 2 heads, an oblique and transverse head. Inserts into the lateral side of base of proximal phalanx and sesamoid bone. It is responsible for adducting the big toe. The abductor hallucis muscle is located in the medial border of the foot and inserts on the medial surface of the base of the first proximal phalanx and the medial sesamoid bone. Its function is to abduct the great toe. Hallux valgus deformity is defined as a lateral deviation of the great toe on the first metatarsal towards the little toes. As a result, the metatarsophalangeal joint moves farther and farther medially, so the medial capsule and medial collateral ligament come under chronic strain, and eventually become weaker and the valgus deformity is created. The medial joint capsule tension and collateral ligaments tightening lead to the bone to proliferate on the dorsomedial aspect of the first metatarsal head called bunion. Over the time, a medial bursa protecting the joint will be inflamed, exacerbating the pain. In hallux valgus, the longus flexor and extensor tendons and adductor muscle become a deforming force. In the hallux, the abductor hallucis muscle loses its normal anatomical relationship with the metatarsophalangeal joint, shifting to the plantar aspect of the first metatarsal rather than medial to it. The muscle therefore loses its abductory force. Lateral tension causes the sesamoid apparatus to stick in a dislocated position laterally. Over the time, a degeneration of the plantar surface of the metatarsal head, because of erosion as the metatarsal moves over the dislocated sesamoids, may occur. Commonly, the big toe is rotated by its axis, causing the toenail to face medially. In severe cases, degeneration of the cartilage covering the metatarsal head leads to metatarsophalangeal joint osteoarthritis. Causes and risk factors. Wearing poorly fitting shoes. In particular, shoes with a narrow pointed toe box that forces the toes into an unnatural position. Wearing high heels forces your toes into the front of your shoes, often crowding your toes. The tendency to develop bunions might be the result of an inherited problem with the structure or anatomy of your foot. 70% of patients with hallux valgus have family history. The clear predominance of women compared to men with hallux valgus in a 10-to-1 ratio. The hallux metatarsal head is more rounded and smaller in women than in men, as well as ligament hyperlaxity and hypermobility, which are more frequent among females. Certain activities which may put greater force on the forefoot, such as ballet dancing. Dancers put a great deal of stress through the first MTP joint, resulting in hallux deviation. Conditions that affect both the nerves and muscles, such as polio or cerebral palsy. People with connective tissue disorders, such as Marfan syndrome and Ehlers-Danlos syndrome. And those with Down syndrome may be at an increased risk for developing bunions. Being overweight and long periods standing can destabilize the ligaments in the forefoot due to the overload, allowing the transverse arch of the foot to drop and hallux valgus deformity occurs. Inflammation of the metatarsophalangeal joint, including rheumatoid arthritis, psoriatic arthritis, and gout. In S-play foot, the front transverse arch of the foot has dropped. The toes lose their natural forward direction. It is considered a common cause of hallux valgus. Flat feet, where the longitudinal arch of the foot collapses, is also considered as a risk factor. Less common causes of hallux valgus involve second toe amputation. Symptoms. Whilst hallux valgus is a common foot deformity, it does not cause severe problems in all patients. It often bothers female patients; they consider it a cosmetic problem. People with bunions report mild to severe symptoms, including pain and swelling in the big toe joint that gets worse with standing and walking. Pain when wearing shoes, making it difficult to find comfortable footwear. Visible bump on the inside of the foot, at the base of the big toe. Red, sore and calloused skin at the base of the big toe. Stiffness and restricted motion in the big toe, or pain and burning when you try to bend it. Compression of digital nerve may cause numbness or burning feeling. With hallux valgus, stress is shifted away from the painful big toe. Instead, the smaller toes carry more of the weight whilst walking. This causes the metatarsalgia. Calluses may develop where the toes rub against the shoe and because of an abnormal load, causing additional discomfort and difficulty walking. In more advanced cases, the big toe may angle all the way under or over the second toe. There may be deformities of the second or third toes, known as hammer toe deformities. Diagnosis. Your doctor will ask you about your medical history, general health, and symptoms. He will perform a careful examination of your foot. Examine the foot whilst bearing weight and whilst not weight-bearing. Although your doctor will probably be able to diagnose your bunion based on your symptoms and on the appearance of your toe, he will take an X-ray while you are standing in order to more clearly see the malalignment of the bones of your foot. He will use the X-rays to determine the integrity of the joints, to determine how severe the bunion is, and how best to correct it. We will talk about radiographically evaluating the severity of the hallux valgus and determining the appropriate surgery in the next video. Non-surgical treatment. In most cases, bunions are treated without surgery. Although non-surgical treatment cannot actually reverse the deformity, it can help reduce pain and keep the bunion from worsening. Anyway, Treatment of a bunion is only required if it is causing symptoms. If the deformity is flexible, the big toe can still be returned to its original position. Then conservative, non-surgical treatment options can usually relieve pain. Non-surgical treatments include wearing shoes with a wide and high toe box, avoiding tight, pointed or high-heeled shoes. Non-steroidal anti-inflammatory medications, NSAIDs, can help relieve pain and reduce swelling. Applying ice several times a day for 20 minutes at a time can help reduce swelling. At home, you can conduct stretching exercises that promote the free movement of the big toe in all directions to maintain joint mobility. Physiotherapy and strengthening of the small muscles within the foot can help with symptoms of foot pain. Activating and relaxing the foot and toe muscles naturally strengthens and straightens the arches of the foot. Only intact arches can prevent the hallux valgus condition from progressing. If you have flat feet or another inherited structural foot problem, you can use special shoe inserts can help prevent or slow the progression of bunions. Protective bunion shield pads can help cushion the painful area over the bunion. Be sure to test the pads with a wide toe box. The size of the pad may increase the pressure on the bump. This could worsen your pain rather than reduce it. You can also place a spacer between the big toe and second digit. Some people find relief by wearing a splint at night to keep the big toe straight. Steroid injections may reduce pain and swelling, but may also be damaging if used too often or injected into the joint itself. This is often a late treatment of bunions when trying to avoid surgery. If bunion symptoms are severe or persistent, if you have trouble walking, and the symptoms do not improve with conservative management, your doctor may recommend surgery. The most important indication for surgery is pain and dysfunction, not deformity. We don't perform surgery for purely cosmetic reasons. Due to the general medical risk and the postoperative limitations in everyday life. Although there will often be concern about the appearance of foot and about the shoes which must be worn to accommodate this. There are many surgical options to treat hallux valgus. We will discuss them and post-op rehabilitation in next video.